Welcome to this session in the ASNA convention entitled Educating Nurses to Improve Health Literate Communication. Hi, I'm Dr. Felicia Wood, and my colleague Ann Graves and I from the University of Alabama Capstone College of Nursing conducted this research that led to this presentation. We're excited to share some of our strategies with you today and hope these will be helpful to you in your practice. We have nothing to disclose. The research that we conducted was funded by a grant from Sigma Theta Tau International and the Chamberlain College of Nursing. You can see the learning objectives here. By the conclusion of this presentation, you should be able to design a health literacy education module for practicing nurses. You should be able to describe 3 strategies to assess and promote improved health literacy for consumers, and assess organizational efforts to promote health literacy within the healthcare system. There is a definition that has been used for, I guess, about 16 years. The definition for health literacy has been, up until this current time, the degree to which individuals can obtain, process, and understand the basic health information and services they need to make appropriate health decisions. As you can see, this definition was used in Healthy People 2010 as well as Healthy People 2020. I am pleased to report, however, that Healthy People 2030 was released a couple of weeks ago, and the definitions have changed for health literacy. Now there are 2 definitions, the first being personal health literacy, which you can see here is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Additionally, there's now an organizational health literacy definition, which reads, it's the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related actions and decisions for themselves and others. I'm really excited about these definitions because I think this puts the emphasis on not only individual health literacy, but also on organizational health literacy. So what's different? Now the emphasis is more on using health information than simply understanding it. A focus on the ability to make well-informed decisions rather than appropriate decisions, which is really subjective. And a public health perspective is incorporated in these definitions. And finally, as I mentioned earlier, there's an acknowledgement that organizations have a responsibility to address health literacy. So why is health literacy a problem? Well, as you know, as a healthcare provider, healthcare is very complex. The words we use as healthcare providers are like a foreign language to most people. There's too much paperwork involved in healthcare, especially when it comes to discharge instructions. There's too little opportunity to practice, for patients to practice what they learn before they're discharged. And we also have a multicultural society. It's not just language barriers, but the cultures are different. When you think about people living in the southern United States, that's a different culture than other aspects of the United States. So does any of this sound familiar for those of you who've been practicing recently? We always learned that discharge teaching began on the day of admission. However, I don't know that that really has ever happened. So discharge teaching begins on the day of discharge, unfortunately. As the nurse, you say, do you have any questions as the patient's on his way out the door? Patients and caregivers are anxious to leave the hospital if they've been in there for a while, or to leave the clinic or wherever they are receiving their health care. And teaching with patients typically has not included caregivers to the extent necessary, especially now that visitors are not permitted to be with patients as a result of the COVID-19. That's particularly problematic. And I can share a personal example with you that happened just about a month ago. My husband was admitted overnight for a procedure to the hospital. When he was discharged the next day, I didn't receive a phone call about discharge instructions. When I picked him up at the door, I brought him home. And I looked through his discharge instructions. He had 65 pages worth of instructions. Now, the likelihood that he would ever read that is very slim. And I would say that's probably true for most patients and families. Few pieces of information about health literacy. Back in 2016, a study was done that found that only 1 in 4 people reported that their healthcare provider always confirmed how people should follow their instructions. Only 65% of discharged hospital patients reported they always received communication about their medications. 3 of the 2020 National Patient Safety Goals directly relate to communication, including patient identification, staff communication, and medication reconciliation. We know that these national patient safety goals are very important, and health literacy needs to be incorporated in all of these: the patient identification, staff communication, and medication reconciliation. Low health literacy increases healthcare costs. That has been well documented, and we know that healthcare is extremely expensive today and creating a tremendous burden on not only the individuals, but also the country as a whole. We also know that rural dwellers have lower health literacy than urban dwellers. That has been documented in numerous studies, and we realize that Alabama is a rural state. So please keep that in mind as you're educating people. According to a statement by New Readers at the multi-state 15th Annual New Readers of Iowa Conference back in 2004, the statement was made: a doctor's office is no place for a reading test. When information is given to people, when they're asked to fill out forms, and now we're using tablets for filling out forms, and people don't understand what some of those words mean. So it's not really a place for a reading test. People need to providers need to be using plain language. And it's the duty of all healthcare providers to promote understanding. Health literacy is not an add-on service, but it's part of everyone's job, not just nurses. So how do you know if somebody has low health literacy? Well, there are lots of cues that should give you an idea that the person probably needs some sort of assistance. The first one, probably the most common one, is I forgot my glasses. The next one is, and this happens to me all the time, I'll wait for my wife to fill out the forms. So I always have to fill out all the forms for my husband. He is not health literate. And please realize there is no picture of the person with low health literacy. We're not saying low health literacy is the same as low literacy. Healthcare is a very unique language, and there are lots of people who are extremely literate, brilliant people who have no idea about the healthcare language. How many of your non-healthcare provider family members understand when you talk about an ophthalmologist or an otolaryngologist? Probably not very many would understand those terms. Low health literacy is rampant, I'm sorry to say. We learned that language of healthcare when we went to school, and we were so proud of those words. We wanted to be able to use those. We wanted to talk about voiding. We wanted to talk about different procedures and use the correct terminology, which we were required to do. Well, now it's time for us to back translate all of that for our patients. So the nurses who really demonstrate their knowledge are the ones who use the plain language. Have you had any health literacy education since your basic nursing education? Most people have not. And that was the basis for this grant, for this research that we conducted. The grant was funded, as I said, by Sigma Theta Tau and the Chamberlain College of Nursing. And what Dr. Graves and I did was to create and test a health literacy education module for students in Masters of Science in Nursing programs here in the Capstone College of Nursing. And we used a pre-post intervention methodology. The module objectives, and we're not going to go into the research here today. What we want to do is educate you about health literacy so that you can use health literacy in your practice. What we did in developing these modules was to incorporate a health literacy assessment into the patient assessment. We asked students and taught them how to assess the readability of existing patient education materials. We had them modify existing patient education materials to promote readability and understanding. We also helped them to understand and use the teach-back method to validate understanding of patients and caregivers. Use of plain language in verbal and written communication. We forget about the written communication sometimes. And we assessed elements of health literacy that were embraced in the healthcare organization. So students learn to do all of these things. So what about a health literacy assessment? You know, there are lots of different health literacy assessments available. I used one several years ago in research. It's called the Realm. It's a 66-item tool, and people are asked to read each word on the list and then stop when they can't read at the one that they can't read. So if they read 36, then their score is 36 out of 66. If they come to that 37th one and can't read it, so that's when they stop. There are lots of different tools available. Currently, and this is a relatively new recommendation within the last year, is that an assessment really shouldn't be done. Instead, we, as healthcare providers, should be treating everyone as if they have limited health literacy. Don't try to look at somebody and decide, you know, I think that person really understands. I don't have to explain or use the teach-back method with this person. That's not a good strategy. However, if you insist and want to use an assessment, this is one that I've actually seen on some hospital paperwork, which was very impressive to me. And it's a single item, and you simply ask, how often do you have someone help you read hospital materials? That's easily incorporated into an admission assessment. And, you know, the range is, you know, all the time, rarely, you know, some of the time it's on a Likert scale, so that can be easily added. Readability of patient education materials, very important to assess readability. And although grade levels, you know, are good, they're not perfect. So they may not be accurate, but they can give you a global idea of how to go about reading, the difficulty in reading a document. As I said, there is no perfect tool. There is a readability assessment here. It's called readabilityformulas.com. It's a free tool. And if you put a paragraph, or if you even put a whole document in, it will assess the readability, and it will use different kinds of tests to assess that readability. So I encourage you to explore that and see what changes you can make in a document, and then go back and try it again to see how it's been improved. Modifying patient education materials is a huge job. I know that a lot of organizations now purchase their patient education materials, and that's great. However, even if they're purchased, you still need to review those to make sure that they are applicable for the population that may not understand the terminology. So if you're going to tackle modifying patient education materials, I strongly encourage you to start small. Don't start with a large document, a 6 or 8 page document. Start very small with a 1-page document. Assess the readability, make changes, use plain language. And if you are considering purchasing some patient education materials, make sure you check the readability first and ask the vendor, you know, what health literacy strategies have you incorporated into your materials. So I encourage you to explore all of that, and don't try to take on everything in the organization. There have been several articles published that discuss the importance of taking a very slow, methodical approach, sharing the joy with others, teaching others in the organization how to to modify those patient education materials. It's not a job for one person, and not even for a small committee. So, but it is a very important thing to do, is to look at those documents and see what's there that's outdated, what's not evidence-based, but most importantly, what needs to be improved as far as health literacy. So there are several toolkits, strategies that you can use. AHRQ has a health literacy universal precautions toolkit, which is extremely helpful. And I'm hopeful you'll be able to access that and use that as you choose to make modifications in your patient education materials. Another document that's very helpful is from the CDC, and it's a plain language dictionary. It's everyday words for public health communication. There are other resources that offer plain language dictionaries as well, so I encourage you to kind of search that out, but I particularly like the one from the CDC. That's been very helpful. Helps you switch out words. You know, we may say void. You know, it's okay to say urinate or pee. That's okay. You have to understand your population and what they need to know and the words that they use. The teach back strategy. I really love this strategy. I think it's what we all need to be using. It does take practice, and you need to use it consistently in order to really improve your skill with it. What you need to realize is it's not a test of the patient's knowledge, but it's a test of how well you explain the concept. So it's very important when you're teaching, and I'm sure you remember this, that you want to avoid times when the patient's tired. And you also want to be sure that you're including caregivers. And in this time of COVID-19, one strategy is to plan ahead and talk to the caregiver on the phone and say, okay, when is a good time when we can talk, all three of us? If FaceTime's available, I know some institutions are using iPads and different strategies to FaceTime patients with caregivers. And if teaching can be planned around that, that would be very helpful. The teach back strategy explains what the person needs to know. There's a difference between needs to know and nice to know. Nice to know is great, but you want people to be able to understand exactly what they need to know. Don't try to conduct all the teaching in one session. That's very difficult. You need to allow time for application, for the patient to apply what they have learned, and begin each session by asking, what did you learn in your previous session? And you should have a list of what was taught. Maybe it was taught by a different nurse. So then you can answer any questions, offer the opportunity, say, you know, what was not conveyed to you clearly, and how can I help you? Don't just ask, do you have any questions? Because that, most times people are going to say no. And my husband is infamous for that. He'll say, no, I don't have any questions. We get outside the door and he'll say, what did they say? What was it? What am I supposed to do? So don't necessarily assume that because somebody sits there and nods their head and said, oh yeah, I understand everything. Instead, have them teach you back what they learned. You can do that by having the patient list what you taught the patient, having them describe what you taught them, and most importantly, having them demonstrate if there are skills involved. Chunk and check is a very important part of the teach back strategy, and that involves breaking the teaching down into small segments within each larger session. That way you can check the learning throughout the teaching session. If you're going to be teaching someone how to administer insulin, well, you have to teach the person how to read the syringe, how to draw up the insulin. There are a lot of different steps. So break those down. First thing is knowing what the dose is, and then looking at the insulin bottle, looking at the insulin syringe. And stop there and say, okay, let's go back and practice this. And it seems like you're not getting anywhere because you're thinking, oh, I have all these other patients to take care of. But I believe that if we will do this, if we will use the chunk and check and the teach back strategy, that would be one effective strategy to prevent readmissions. And we all know that 30-day readmissions cost the institution a lot of money. Okay, so the show me strategy. Show me how to take your medications. Show me how to perform your blood glucose check. Show me how to perform different skills. Very important to use handouts and make notes for patients. But you need to review all those printed handouts. So don't hand them 65 pages of materials and walk out, as they're walking out the door. It's very important for you as the nurse to review those printed materials with the patient, highlight what's most critical. Take your highlighter in there when you're talking with the patient, and encourage the patient to make notes or reminders. And if you see that the person's not writing anything down, then you need to ask them, did you want me to make a note of this? Because they may have some difficulty with that. Okay, so one strategy that we had the students use in the research, and which I hope you will embrace as well, is a teach back self-evaluation log, looking at what you're doing and how effectively you're doing it. So you can do this. Of course, you don't want to violate HIPAA. You don't want to put any patient information that would divulge anything, any personal information. But if you just keep a list of, patient who had the cholecystectomy, and then list the items to do or to remember. Okay, so, and then did you use teach back during your teaching? There may be times when you don't, don't punish yourself for that. And then what were the results of that? Did the patient need clarification? What was the patient's, perception? What was your assessment of your effectiveness? And be honest with yourself, because this is a self-evaluation. You're not turning this in for a grade. And then it's very important to list what things might you do differently next time. I apologize. I know this is very difficult to read, but a researcher named Toronto, she conducted her dissertation research on developing health literacy competencies for registered nurses. And these are extremely important if we're going to be effective in providing health literate education to our patients. So I'll just share a few of these competencies, and then, hopefully you can use this document. You can also look up the article and print this off. But, excuse me, one of them is that you can't tell who has low health literacy by looking at someone. So are you feeling competent with that? Or do you still sometimes slip and say, I really thought that person was competent with health literacy, but now I'm finding out maybe not so. A person who is competent in their health literacy skills never assumes the patient's understanding. Another example is health literacy may decrease during times of physical or emotional stress. We realize that people are stressed, especially right now with everything that's going on in the world, and health literacy may decrease during these times. So someone who didn't have difficulty before now may be struggling with their health literacy. It's important to differentiate the ability to read and reading comprehension. Some people can read quite well, but their comprehension may not be good. So be careful that you're not giving people too much material to read on their own without your explanations. As I mentioned earlier, there are cultural and linguistic differences that do magnify health literacy issues. Using a variety of education materials, verbal, written, pictures, videos, all of those can help to increase patient understanding. If there are models that can be used as a part of your teaching, that will help to increase health literacy as well, patient understanding. And patient and provider communication truly is influenced by the health literacy level of the patient. So if you can acknowledge competence with all of these health literacy skills, you're doing great. Keep going. Good job. The final aspect I'd like to talk with you about today is the 10 attributes of a health literate organization. That's relatively new, and not a lot of organizations, I don't think, have truly embraced their responsibility related to health literacy. So the competencies or the attributes that were identified in the research by Brach et al. First, has leadership that makes health literacy integral to the mission, structure, and operations. Does your leadership put health literacy first? Integrates health literacy into planning, evaluation, patient safety, and quality improvement. So again, it's not just the nurse's responsibility. Prepares the workforce to be health literate and monitors progress. It's extremely important. We cannot assume that everyone in our workforce is actually health literate. There are people who don't have the same level of education as a registered nurse. So it's very important that the organization prepare the workforce to be health literate. The organization needs to include populations served in the design, implementation, and evaluation of health information and services. Meeting the needs of populations with a range of skills while avoiding stigma. Using health literate strategies in interpersonal communications and confirming understanding at all points of contact. And all points of contact, when you think about walking in the door to a healthcare provider's office or institution, all points of contact include much more than just the patient care area. Easy access to health information and services and navigation assistance. When you look at the directions, there's wording up on the wall that explains, how to get to radiology. What if the person doesn't know what radiology is? They're just there for an x-ray. They don't know what radiology means. So making sure that the navigation assistance is written in plain language. Designs, distributes print, audiovisual, and social media content that's easy to understand and act on for the patient. Addressing health literacy in high-risk situations. We know that care transitions are problems, and that communications about medicines can be problematic and lead to errors in care. And we don't want that to happen when the patient is discharged or when the patient is transitioning to a different level of care. So to be sure that those things are addressed. And this is one that I don't think a lot of organizations do, but I was pleasantly surprised a couple of weeks ago when I went to an outpatient place for a diagnostic procedure, and they listed exactly what was the charges were going to be. They didn't say what my health plan was going to cover, but I had never seen what the charges were for some of these procedures. So that was encouraging to me, and I shared that with the person checking me in, and she said, "Oh, I think it's some kind of government regulation." So, whether it is or not, I think it's a good thing. So as far as strategies for improvement of the health literate organization, walking the walk, I think, is really important. Looking at the mission, vision, and value statements. I don't know if you're on any committees in your organization or if you're involved in groups that look at the mission, vision, and value statement, but make sure that health literacy is incorporated in those. And ensure employees are health literate. And I mentioned that about the workforce earlier, but I can give you an example that there were some patient care assistants that were not clear about patients who were on alcohol withdrawal precautions, the CWA protocols. So they didn't realize that they needed to monitor these patients for safety, and bad outcomes resulted. So very important to be involved in those strategies. Committees, groups, all groups need to be considering health literacy. You can see different groups here: billing, policy, finance, ethics. Everybody needs to be looking at health literacy. I involve consumers in efforts to improve, looking at written information, policies and procedures. Do a clinical site walkthrough. That's really important to see what does this look like. And if you involve people, lay people, perhaps they've been patients in the past, in these committees. That's extremely helpful. So serve as liaisons to adult literacy and basic education programs. That's extremely important as well. And modeling patient involvement to others. I think that's always helpful. I hope this presentation has given you some food for thought, and just wanted you to know that if you have any questions, please feel free to contact me, fwood@ua.edu, Felicia Wood, or Dr. Graves at agraves@ua.edu. I've enjoyed this time and hope that this has been helpful to you. Thank you.